Good afternoon. We shall begin the program in 5 minutes. We shall begin the program in 5 minutes. Good afternoon. Before we start the program, we would like to acknowledge our sponsor for this event, AstraZeneca.
Testing to identify BRCA mutations. Mutations in a number of genes have been implicated in ovarian cancer, including tumor suppressor genes VRCA1 and VRCA2, VRCA1 chromosome 17, VRCA2 chromosome 13. BRCA mutations, germline and somatic, are present in approximately 25% of ovarian cancer patients at diagnosis. There are two types of BRCA mutations. 1. Germline, inheritable. Germline mutation present in all cells. Mutation in egg or sperm. All cells affected in offsprings. Present in approximately 6 to 25% of ovarian cancer patients at diagnosis. 2. Somatic, spontaneous, present in approximately 5 to 11% of ovarian cancer patients at diagnosis. An MD Anderson Cancer Center study suggests that 67% of ovarian cancer patients with a BRCA mutation have a germline mutation, while 40% have a somatic mutation and no germline mutation. Guidelines are evolving to recommend BRCA mutation testing in all women with ovarian cancer at diagnosis. Testing for BRCA mutation at diagnosis could help provide a timely, informed decision on the most appropriate treatment strategy for women with ovarian cancer. It also provides information on patient prognosis to platinum chemotherapy response. How to test for BRCA mutations. There are two ways to test for BRCA mutations. Blood testing identifies germline BRCA mutations only. Tumor testing identifies both the germline and somatic BRCA mutations. Around 50% more patients could be identified through tumor testing than through blood testing. BRCA testing algorithm that begins with tumor testing is advantageous. Beginning with a tumor test means fewer tests are required to provide both results for individuals with ovarian cancer and information on familial risk when this is required. To identify the somatic and germline BRCA status of 100 women with ovarian cancer, a study has demonstrated that initial tumor testing followed by germline testing in the event of a positive result is cost-effective in practice. BRCA test in tumor versus blood sample. Tumor. Tumor sample. Surgical procedure. Many steps for sample preparation, including pathology. High amount of DNA. Variability in the sample. Identifies germline and somatic BRCA mutations. Blood. Blood sample. Blood extraction. Simple sample preparation. Low amount of DNA, ctDNA, little variability, easy to get a second sample, identifies germline BRCA mutations only. Different processes are required. There are limitations for BRCA testing methods. Tumor testing. Analysis can be through next-generation sequencing. NGS only allows identification of both germline and somatic BRCA mutations. Challenge may miss a small proportion of germline mutations. Blood germline testing. Analysis can be through Sanger sequencing or next-generation sequencing. NGS allows identification of germline BRCA mutations only. Challenge does not identify somatic mutations.
Welcome to the Society of Gynecologic Oncologists of the Philippines' third Dr. Augusto M. Manalo Tumor Conference for the year. Let us start. This will be followed by the SGOP hymn. For a brief moment, let us pause in our daily preoccupation and feel the strong and reassuring presence of our Lord. Heavenly Father, look with kindness upon all of us who are gathered here. Fill our minds with wisdom and fill our hearts with love and joy as we begin this webinar. Look with kindness upon the leaders of the society. Strengthen our wills and enable us to infuse excellence and relevance in all our undertakings. Look with kindness upon the founders of our society and all its past presidents. May their legacy of hard work and productivity continue to inspire all our members. Look with kindness upon all of us here as we become entangled in the web of our actions. Enable us to feel the warmth of one another's friendship. Look with kindness upon the trainees. May they continue to strive for excellence as they find joy in camaraderie and mutual support. Look with kindness upon our friends in the pharmaceutical industry. May they continue to be our eager partners in all our endeavors. Look with kindness upon all the people for whom this organization exists. The women afflicted with cancer, the women who have recovered from cancer, and the women who are at risk of developing cancer. May our concern for them as deep and pure and genuine as your concern for all of us. And at the end of the day, allow us to raise our hands to you in praise and thanksgiving for allowing all these things to happen. Amen.
Kami ay nandito para sa'yo. Hawak kamay nating harapin ang mundo. Tiwalang binigay sa Diyos inaalay upang makamtan ang inaasam sa buhay. Aming kang inaabot upang ligtas ka. Hangaring tapat, ika'y makakaasa. Ang likod, pagkabay, kasama sa paglalakbay. Pagpayo, pagdinig, pagdatingan, pag-ibig, pagtulong ay sa kasama sa paglalakbay. Pagpayo, pagdinig, pagkalinga, pag-ibig, pagtulong ay sa ang iyong karamdaman. Yan ang aming pangako, yan ang aming pangako.
Good afternoon. I am Dr. Joy Vallega. I will be your moderator for this afternoon's conference. Please allow me to read the House rules. Please use your complete name when attending this webinar for proper identification, especially during the question and answer portion. Please write your questions in the webinar Q&A box anytime. You may write your comments and suggestions in the chat box as well. Please note that this webinar is being recorded. A link of the recording will be sent on a later date for viewing. Please answer the electronic evaluation form to receive the certificate of attendance. The link will be posted in the chat box. So to start off with our program, may I please request our SGOP President, Dr. Maria Lilibeth Siasu, for the opening remarks.
Good
Hello, Ma'am
afternoon.
Lilibeth.
Yes,
Good
can I be
afternoon,
heard?
ma'am.
Okay, thank you. Good afternoon, ladies, gentlemen, and friends. Welcome to the third Augusto Manalo 2020 Tumor Conference. We have a very interesting topic for this late afternoon. It is endometrial cancer transition from endometrioid adenocarcinoma to carcinosarcoma. And this topic will be presented to us by Dr. Mary Lilia Tino, our gynecologic oncologist who chose to practice and serve the women of Bacolod. Joining us tonight, this afternoon, are two brilliant reactors, Dr. Jonathan Rivera, a pathologist of the University of the Philippines, and of course, Dr. Jean Ann Peral, a very sought after speaker, our gynecologic oncologist, and our moderator will be Rose Joy Riega. We congratulate and thank the team headed by Dr. Andy Echo for organizing this event. And special thanks always to Mark Antonio, who has been a great help in all of our webinar series. We would also like to thank our pharma sponsor, AstraZeneca. So, in behalf of the Society of Gynecologic Oncologists of the Philippines, welcome and let's all learn together. Have a good day. Back to you, Joy.
Thank you, Dr. Siasu. So to give us an overview of this afternoon's conference, may I please call on Dr. Ana Victoria D. Echo, the chair of the 2020 SGOP Tumor Conference. Ma'am Ana?
Hi, Joy. Thank you. So, good afternoon, everyone. Again, I'd like to thank everyone for attending the third SGOP Dr. Augusto M. Manalo Tumor Conference release. So, as mentioned by Dr. Shasu, no, our topic for today will be quite interesting. So, we will be presented with a case of endometrial cancer, which had a transition from endometrioid adenocarcinoma to carcinosarcoma. And this transition brings about a lot of questions. First, is the transition from endometrioid carcinoma histopathology really possible? Or could this be two different entities presenting at different times? And could this be an important impact to the management of the case? Hopefully, our speaker, as well as our reactors, will be able to fully answer these questions and give us a good insight on such histopathologic transition. I would like to remind everyone that you need to answer the evaluation form, which we will post in the chat box during the conference to be able to get your certificates of attendance and also get the full credit of 3 CPD units. So please do enjoy our discussion today as you did in the past conferences. And hopefully through the tumor conferences and through our speakers and reactors, we, the SGOP, are able to share our knowledge and thoughts regarding interesting gynecologic cancer conditions which we may encounter in our practice. Thank you very much and enjoy the afternoon.
Thank you, Ma'am Ana. So please allow me to introduce our presenter and first speaker. So our presenter finished or completed her residency training in OBGYN at Manila Doctors Hospital. She then proceeded with fellowship training in gynecologic oncology at the University of the Philippines Philippine General Hospital. She is a fellow of the Obstetrical and Gynecological Society, the Society of Gynecologic Oncologists of the Philippines, the Philippine Society for Cervical Pathology and Colposcopy, and she is the present training officer of the Department of Obstetrics and Gynecology at the Dr. Pablo O. Torre Memorial Medical Hospital. Let us all welcome our presenter, Dr. Mary Lilia Bernadette V. Tino.
Nakamute. Yes, Tom. Okay. 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 I'll go. Thank you. Good afternoon, everyone. Thank you, Dr. Joy, for that kind introduction. I'll be talking this afternoon about endometrial cancer, transition from endometrioid adenocarcinoma to carcinosarcoma. Patient is EM, a 68-year-old Gravida 3 Para 2, 2012 with a chief complaint of vaginal spotting. Patient was hypertensive and diabetic. She had a family history of goiter and hypertension. She worked as an office staff and widow for 17 years. Patient is a G3P2 2012, two pregnancies carried to term, delivered spontaneously, with one spontaneous abortion. History of illness started with vaginal spotting of unrecalled duration. On December 15, 2017, the patient underwent endometrial and endocervical curettage. This is the picture on low power view and high power view of the specimen. You can see irregular and fused glandular structures lined by anaplastic cells, and there are round to pleomorphic nucleoli and scanty cytoplasm. This was read as endometrioid adenocarcinoma grade 1. Patient was referred to a gynecologic oncologist. In February 2018, the patient was seen with a BMI of 25.79, obese class 1. Internal examination showed a normal external genitalia, smooth and porous vagina, cervix was smooth, corpus was small, no adnexal masses, bilateral parametria smooth and pliable. The following month, she underwent exploratory laparotomy, peritoneal fluid cytology, total hysterectomy with bilateral salpingo-oophorectomy, bilateral pelvic lymph node dissection. The intraoperative findings showed that the liver The spleen, subdiaphragmatic areas, kidney surfaces, omentum appendix, and gastric and intestinal surfaces were all smooth. There were no palpable pelvic nor para-aortic lymph nodes. This is the specimen taken from the patient. The uterus measured 8 by 6 by 5 centimeters with smooth surface. On cut section, it showed that the endometrial cavity was 4 centimeters and with a 2.5 centimeters endocervical canal. You can note here the presence of submucous myoma, a 3 by 3 by 3 centimeters, attached to the posterofundal wall. You can appreciate here the presence of endometrial tumor inferior to the submucous myoma, measuring 3 by 2 by 1 centimeters. The rest of the endometrium was thin, zero point 0.1 centimeters, and the anterior myometrium measured 2 centimeters anteriorly. The right and the left ovaries were grossly unremarkable. Harvested pelvic lymph nodes were not suspicious for malignancy. This is the histopathology. We can appreciate here interlacing fascicles of smooth muscles, which points to a myoma with overlying malignant neoplasm. The tumor is noted to be limited to the overlying endometrium of the benign submucous soft tissue tumor. This is another area which shows us few islands of benign endometrial type glands surrounded by endometrial stroma deep within the myometrium, which points to an adenomyosis. This is another picture just to show us of the myoma and the adenocarcinoma. Focusing on the adenocarcinoma, you can see confluent papillary and polygonal glands. On high magnification, there are cribriform glands lined by neoplastic columnar epithelial cells, having ovoid to pleomorphic and vesicular to hyperchromatic nuclei with occasionally prominent nucleoli and scant to moderate abundant cytoplasm. This is another part of the endometrium where you can see dilated glands lined by columnar to flattened epithelium. This points to an endometrial polyp. This was signed out as peritoneal fluid cytology, acute and chronic inflammatory pattern, endometrial adenocarcinoma endometrioid type, moderately differentiated, 3 centimeters in greatest dimension. Tumor is limited to the endometrium, overlying the submucous myoma. The final diagnosis, endometrial adenocarcinoma, endometrioid type, FIGO grade 2, stage 1A. Status postperitoneal fluid cytology, total hysterectomy with bilateral salpingo-oophorectomy, and bilateral lymph node dissection. The plan post-operative was for observation. The course of the patient, she had regular follow-up and was asymptomatic, with no evidence of disease for 1 year and 6 months. However, 1 month after, she experienced bloatedness with increasing abdominal girth. This time, abdominal circumference was 97 centimeters. There was a note of a 15 by 12 centimeter mass. On internal examination, you can appreciate the inferior pole of the mass. CA125 at this time was 589.1, elevated. This is an abdominal MRI with contrast. This is an axial view. This is the anterior part, and this is the posterior part. This is the right side of the patient and the left side of the patient. This is at the level of the pelvis. And we can see here a large, fairly defined lobulated heterogeneous focus with cystic components, more on the left lower hemiabdomen and pelvic cavity. This mass measured 13.6 by 15.6 by 12.6 centimeters. This is a coronal view at the level of the liver. This is the liver and this is the spleen. You can see the spleen is enlarged with a lobulated mass with internal septations. It measured 7 by 7.2 by 6.8 centimeters. This is the axial view. This is the liver, and you can note white areas here and also at the perisplenic area, which points to a moderate ascites. Anteriorly, you can see here omental and mesenteric caking. This is at the level of the femoral head, and we can see here the rectum. And we can appreciate pelvic soft tissue masses, the largest at the perirectal area, measuring 6.4 by 5.3 by 4.3 centimeters. This is the official result of the MRI. Impression, working diagnosis at this time is tumor recurrence. The patient was started on paclitaxel and carboplatin every 3 weeks, and she had 3 cycles. And at this time, there was a note of an increase in the mass, abdominal mass. This time, it measured 20 by 20 centimeters. Another abdominal MRI with contrast was done. This is a coronal view, and we can still see here the large lobulated heterogeneous mass with cystic components, now measuring 20 by 25.3 by 13.6 centimeters. This is an axial view. This is the T1 weighted and the T2 weighted image. And we can see here, these are the bowel loops. Adjacent bowel loops are splayed peripherally, and you can see good planes with the adjacent bowel loops. There are still the peritoneal, intraperitoneal, and pelvic soft tissue masses with omental and mesenteric thickening. This again is at the level of the liver and the spleen. You can note here that the spleen now is normal in size, but still with a lobulated mass, measuring 7.1 by 5.3 by 8.7 centimeters. Still with the presence of the perihepatic and the perisplenic ascites. The MRI official result is as follows. Diagnosis at this time, tumor progression. Patient was referred to general surgery for surgical planning of tumor debulking. The patient underwent exploratory laparotomy, enterolysis, tumor debulking, splenectomy, Hartmann's procedure, and insertion of Jackson-Pratt drain. Intraoperative findings, there was 3 liters of serous ascites. Segments of small bowels were adherent to the anterior abdominal peritoneum. The abdominal mass was adherent to the mesentery of the descending colon, rectosigmoid colon, left abdominal wall, pelvic side wall, and cul-de-sac. Aggregate measurement of the mass was 33 by 20 by 15 centimeters, friable, solid, necrotic mass with cystic locules. The liver surface had a 3 by 3 by 2 centimeter tumor implant, and there were sub-centimeter tumor implants in the omentum as well as the small bowel mesentery with an aggregate measurement of 2.5 centimeters. This is the spleen, which measured 14 by 10 by 5.5 centimeters with multiple surface implants. The largest was 4 by 3.5 by 3.5 centimeters. On cut section, there was a solid mass, which measured 5 by 2.5 by 5 centimeters with friable and necrotic areas. This is a picture of the resected rectum measuring 23 by 5 centimeters with a tumor implant measuring 11 by 4 by 5 centimeters. There were no residual tumors after this resection. Estimated blood loss was 2.5 liters, and intraoperatively, the patient was transfused with 6 units of packed RBC. This is the pathology slides of the adenocarcinoma. You have malignant glandular structures mixed with malignant stroma. This is the sarcomatous component, and the sarcomatous element with morphologic features histologically compatible with rhabdomyosarcoma differentiation. These are composed of large anaplastic cells with highly pleomorphic nuclei, prominent nucleoli, and pinkish cytoplasm. There is also presence of tumor cells in this lymphatic vessel. So there is positive LVSI. This was signed out as carcinosarcoma with heterologous differentiation, rhabdomyosarcomatus, 18 centimeters in greatest tumor dimension, and positive for tumor, the pericolic fat, 3/6 pericolic lymph nodes, the spleen, omentum, omental implants, mesenteric, liver, and small bowel implants, positive for LVSI. All the surgical lines of resection were negative for tumor. Final diagnosis, carcinosarcoma stage 4B. The plan was to give the patient ifosfamide paclitaxel. However, uh, we were on COVID. We had the COVID situation, and the patient was not able to follow up. And 3 months post-operative, the patient expired. So I will be discussing first about carcinosarcoma. It's a rare tumor with an incidence of 2 to 5 per 100,000 women per year. It is extremely aggressive with poor prognosis, with a 5-year survival rate of 33 to 39%. The mean age is in the seventh decade, which is compatible with our patient, but it can happen from the fourth to the 10th decade of life. The most common presenting sign is the vaginal bleeding. And often, there's also appreciation of a polypoid mass protruding from the cervical os. Most commonly, carcinosarcomas arise from the uterine body, but it can also arise from the cervix, ovaries, fallopian tube, and vagina. Extragenital sites are the spleen and the peritoneum. Potential sites are the retroperitoneum, greater omentum, colonic serosa, and mediastinum. The behavior of carcinosarcoma is significantly worse than a poorly differentiated endometrioid type, serous and clear cell carcinoma. Comparing the 3-year disease-free survival for high-grade endometrioid carcinoma, it's 87% compared to 42% for carcinosarcoma. So when we say carcinosarcoma, they are composed of malignant epithelial and mesenchymal components by light microscopy. It gives a biphasic appearance. You have the epithelial component and the sarcomatous component. For the epithelial component, the most common is the endometrioid type, but it can also be the serous, the clear cell, squamous, and basaloid. For the sarcomatous component, it can be homologous versus heterologous. For homologous, if there's presence of tissues native to the female genital tract, like the smooth muscles or the endometrial stroma. For heterologous, if there's presence of tissues which does not normally occur naturally in the female genital tract, like skeletal muscles, which is present in our patient, rhabdomyosarcoma, or it can be cartilage, bone, or fat. So there are two theories in carcinosarcoma for its biphasic appearance. We have the biclonal and the monoclonal. In the biclonal, it says that the carcinosarcoma are two independent tumors, a carcinoma and a sarcoma that develop independently, in close proximity to one another, but remain macroscopically and histologically distinct. This is the collision theory. For monoclonal theory, it says that malignant epithelial tissue undergoes a process of metaplastic dead differentiation to give rise to the sarcomatous elements, a process known as the epithelial mesenchymal transition. And this is also the conversion theory. In this diagram, you can see the epithelial to mesenchymal transition, or the EMT. It is an orchestrated series of events in which cell-to-cell extracellular matrix interactions are altered to release epithelial cells from the surrounding tissue. Here, the cytoskeleton is reorganized to confer the ability to move through a three-dimensional extracellular matrix, and a new transcriptional program is induced to maintain the mesenchymal phenotype. When these tumor cells gain these capabilities, they are able to invade surrounding tissues, migrate, and colonize distant organs. In the FIGO 2014 WHO classification, they recommended the use of the carcinosarcoma rather than the mixed Müllerian tumor because carcinosarcomas are primarily epithelial malignant neoplasms with areas of mesenchymal and spindle cell differentiation. It is now staged like that of the carcinomas of the endometrium. Recent clinical pathologic, immunohistochemical, and molecular genetic studies provide evidence that carcinosarcomas develop due to divergent differentiation and or tumor progression, as we have seen, or bidirectional differentiation from a single multipotent stem cell. So tumor initiation and progression. A tumor originates from a clonal expansion of a single cell that has acquired the ability of extensive self-renewal and unlimited proliferation. Two important mechanisms that contribute to tumor initiation and progression uh, contribute to tumor initiation progression. During tumor initiation, dead differentiation, you have dead differentiated cells, and the acquisition of stem cell-like properties increase the number of tumor-like initiating cells, and this favor self-renewal. During tumor progression, there is induction of your EMT, the epithelial mesenchymal transition. Cancer cells are extremely plastic or flexible. There is continuous alterations in the cells as they enlarge. There is a never-ending deconstruction and reconstruction, and these are induced by intrinsic and extrinsic factors. For the intrinsic factors, there are mutations in the oncogenes and tumor suppressor genes that alter the morphology, the metabolic state, the proliferation capacity, the motility of cells, as well as interaction with the other cells in its vicinity. One proof to this is the formation of new blood vessels, the angiogenesis. For the extrinsic factors, you have tumor microenvironment. Tumor cells have the great ability to adapt and contribute to tumor heterogeneity. So carcinosarcomas are now with more evidence to be a monoclonal tumor, and it's seen that the carcinomatous component is the driving force. So we can see here that most properties of carcinosarcoma are from the carcinomatous component, like the pattern of spread. It's more akin to the carcinomatous component, which is the lymphatics, compared to a sarcoma, which spreads through the hematogenous route. The cause of death is due to locally recurrent pelvic and abdominal disease, and tumor metastasis and LVSI consist mostly of carcinomatous elements. The mitotic and proliferative indices are higher in the carcinomatous component. Angiogenesis, expression of proteins are also higher in the epithelial component. Other studies that prove that it's a monoclonal tumor are in the immunohistochemical studies, there is expression of epithelial markers within the sarcomatous component. And there is concordance of immunohistochemical staining of the p53 protein as either being positive or negative. It means that it is an indirect evidence that both components are derived from a single stem cell and do not represent independent carcinomas and sarcomas. Molecular studies show identical patterns of X chromosomal inactivation found in both the epithelial and the stromal component. This support the monoclonal theory. In our case, it's an extragenital carcinosarcoma. Extragenital carcinosarcoma is extremely rare, and the pelvic peritoneum is the most frequent site. There are only very few well-documented cases. In one journal that I've read, it's case report released in 2013, and they did the number of reported cases up to that time, reported cases was only 35. There are three possible mechanisms. One is, in the presence of endometriosis, malignancy can theoretically arise from this ectopic tissue. We are now seeing that endometriosis has a protean ability to grow, to differentiate, and to spread. So in this article, Mullerian carcinosarcoma arising from intestinal endometriosis, that there is malignant transformation of intestinal endometriosis, otherwise known as EAIT, endometriosis associated intestinal tumors. The criteria for diagnosis was to include the presence of endometriosis in close proximity to the malignancy, absence of a likely primary tumor, and histologic features supporting origin from endometriosis. Uh, it was seen in this study that estrogen exposure predisposes the patient to the development of carcinosarcoma in the presence of EAIT. So in our case, is there an endometriotic foci? So with the presence of the adenomyosis in the hysterectomy specimen, maybe it's not far. Another theory for exogenital carcinosarcoma is the splenogonadal fusion, where there is abnormal connection of the spleen to the female mesonephric derivatives, leading to a possibility of displacement of Mullerian-derived tissue to this exogenital site. And the third is because of possibly from secondary Mullerian system. So unlike the primary Mullerian system that gives rise to the uterine body, fallopian tube, cervix, and upper vagina, the secondary Mullerian system consists of parietal and visceral peritoneum and the underlying mesenchymal tissue that retains its potential to differentiate into gynecological tissues. So this is a diagram. This is the embryology. You have the coelomic epithelium and the coelomic cavity, and which gives rise to your peritoneum. And here is the Mullerian duct. So derivative of the coelomic epithelium retain the potential to differentiate into Mullerian tissues. And these Mullerian type tumors may originate directly from totipotential cells or from transformation of the neoplastic epithelial cells into sarcomatous component. Is there a link between endometrial adenocarcinoma and carcinosarcoma? Both share similar risk factors, obesity, which is present in our patient, or there's exogenous source of estrogen, nulliparity. It can also occur with tamoxifen use and radiation treatment for cervical and rectal cancers. They also both share clinical features like metastasis to the pelvic and para-aortic lymph nodes, pelvic soft tissues, vagina and peritoneal surfaces, and lungs. We know now that endometrial carcinoma has two types based on demographic and pathologic studies. You have the type 1 and the type 2. The carcinosarcoma belong more to the type 2 with a similar molecular genetics. In one study report I came across with entitled Mutation Profiling in Uterine Carcinosarcoma, it demonstrated the presence of at least two major genetic types of uterine carcinosarcoma, each with its distinct gene mutation profiles, different for endometrioid carcinoma-like profile and serous carcinoma-like profile. And it proved that uterine carcinosarcomas arise from sarcomatous transformation or transdifferentiation of a pre-existing carcinoma, maintaining the mutation profiles of the pre-existing carcinoma. So this is the diagram to explain it. You have the type 1, which is the endometrioid-like genotype, and you have the P10 mutations with additional mutations. It can be the PIK3CA or the KRAS, and with the addition of TP53 mutations, it can lead to the formation of carcinosarcoma. In serous-like genotype in the type 2 with the TP53 mutation and with the additional mutations, it can lead to the development of carcinosarcoma. Treatment is still surgical. total hysterectomy with bilateral salpingo-oophorectomy, lymph node dissection, and resection of all gross disease is the most effective treatment. Radiation is given for loco-regional control. However, radiation does not improve the overall survival. Chemotherapy in the form of ifosfamide and paclitaxel gives an overall survival of 13.5 months versus the 8.4 months for ifosfamide alone. Prognosis. Surgical stage is the most important prognostic factor. Extrauterine extension, deep myometrial invasion, positive LVSI are independent predictors of survival. They said that presence of the serous and clear cell carcinoma have a significant tendency for metastasis. Advanced age is associated with poor outcome. For extragenital carcinosarcomas, most die within 1 year. Issues most critical to proper diagnosis and management. First, one is we have to identify the patient at risk for these neoplasms. Rare extragenital carcinosarcoma, this patient is a rare case of extragenital carcinosarcoma that came within 2 years from being diagnosed with endometrial adenocarcinoma grade 2 stage 1A, which is a low risk kind of adenocarcinoma. To determine appropriate methods for identifying or excluding carcinosarcoma, we have to raise awareness to improve recognition and earlier referral to appropriate specialists. Assess variables that affect outcome and influence therapy. The importance of prompt identification and comprehensive preoperative staging cannot be overestimated. But due to scarcity of cases and absence of adequately powered clinical trials, optimum management strategy remains elusive. These are my sources. Thank you and good evening.
Thank you, Dr. Ratino, for that very interesting discussion. So, this afternoon, we are blessed to have two brilliant reactors. Our first reactor is a pathologist. He is Dr. Jonathan Rivera. He is a diplomate of anatomic and clinical pathology from the Philippine Board of Pathology. He is also a consultant at the Department of Laboratories of the Philippine General Hospital. He serves as biosafety officer in the Department of Laboratories at PGH. And he finished his residency training in anatomical and clinical pathology also in the same institution and has authored several locally and internationally published scientific papers. May we have Dr. Rivera, please?
Good evening to everybody. I'm Dr. Rivera, and thank you. I would like to first congratulate Dr. Atino for that very comprehensive presentation of carcinosarcoma. So basically, as a reactor now, as a pathologist reactor for this conference, I'm going to just review some of the points that she previously touched on. So in this presentation, I'm going to again discuss the previous histopathologic findings, starting from the biopsy specimen, going to the total hysterectomy specimen, and then to the AP abdominopelvic recurrence of the tumor. And then I'm also going to have a brief discussion about the histopathogenesis of carcinosarcoma. So for the histopathology, so let's start with the endometrial scrapings. So as we've seen in the slides of Dr. Atino, this is the endometrial scraping tissue biopsy. As you can see, it's actually quite scant. The tissue fragments are admixed with this mucoid material, but despite the sparse amount of tissues here, it's actually quite informative. You can see this proliferation of endometrial glands without any endometrial stromal component. The glands are atypical, they are neoplastic, and they tend to form this cribriform architecture, as well as some degree of papillary and villus patterns here. So higher magnification of that focus, you can see that the glands are lined by this plastic columnar epithelium with polygonal nucleoli. Um, with polygonal nucleoli. So this is compatible with endometrioid adenocarcinoma, well differentiated or FIGO grade 1. Now let's go to the total abdominal hysterectomy specimen with bilateral salpingo-oophorectomy from the National Kidney and Transplant Institute. So as you can see, there is a myoma underneath the malignancy on top. So the myoma is well defined, it's bland, it's comprised by this banal proliferation of spindle cells or smooth muscle tissue. And then on the top, you can see the complexity, architectural complexity of the neoplasm. So further focusing on the endometrial malignancy, you can see this proliferation of very complex endometrioid type glands. So the lumina of the glands are fused and they form this very complex labyrinthine pattern. On the left-hand side of the picture, you can also appreciate necrosis and hemorrhage. This is just another picture of the malignancy. Aside from the viloglandular architecture, you can also see this pronounced papillary formation. Higher magnification, we can see that the glands are lined by malignant columnar cells or columnar epithelium with very hyperchromatic nuclei, showing some degrees of loss of polarity and at the same time pseudostratification. Highlighted are numerous mitotic figures. So all of those features are compatible with an endometrial adenocarcinoma, endometrioid type, moderately differentiated FIGO grade 2 because of the marked atypia of the cytology. The tumor is limited to the endometrium overlying the submucous myoma. So the tumor is negative for lymphovascular space invasion and does not involve the uterine myometrium, the LUS, the cervix, bilateral fallopian tubes, ovaries, and soft tissue adnexa. All of the lymph nodes harvested are negative, and the other findings are listed as below. Now let's proceed to the abdominopelvic soft tissue mass. So this is just a scanning magnification of that mass. As you can see, there are no specific patterns seen. What we're looking at are just these variably sized clusters of poorly differentiated malignancy, as well as irregular sheets of those neoplastic cells here, intermingled with those viable neoplastic tissues is this large swath of tumor necrosis in the middle. Higher magnification show this very nondescript proliferation of malignant cells. Some of the cells here are round, polygonal. Some of the cells here have that almost spindled appearance, forming short fascicles. However, further sections of the tumor reveal this very beautiful biphasic appearance of the neoplasm. As you can see, the malignancy is comprised by sharply demarcated, haphazardly infiltrating malignant glands, which is compatible with your adenocarcinoma. In the middle is the very cellular and atypical sarcomatous component. Higher magnification will show juxtaposition or sharp delineation of the adenocarcinoma comprised of papillary and micropapillary features. And then on the top left, you will see the solid proliferation of sarcomatous stroma. Quite interesting is the cells comprising the stromal component. The cells have very abundant eosinophilic cytoplasm, imparting a globoid appearance to some of these sarcoma cells. Higher magnification reveals that the epithelium lining the adenocarcinoma have this very crowded nuclei. Majority of the nuclei have this very prominent nucleoli or what we call macronucleoli, and several mitotic figures are identified. So it seems that the adenocarcinoma has a high grade. Next is the sarcoma component. The sarcoma cells have this abundant eosinophilic cytoplasm, and then the nuclei is very round and is almost always pushed to one side because of the abundance of the cytoplasm. As you can see in the middle here, this is one of the sarcoma cells, and it's quite elongated. So that is a strap cell. So all of these features are compatible with rhabdomyoblastic differentiation, or basically differentiation into neoplastic immature skeletal tissue. skeletal muscle tissue. So for the sake of this presentation, we actually did immunostains for this case. So first we did Desmin. Desmin is just an immunohistochemistry stain to demonstrate myeloid differentiation or muscle differentiation. As you can see, the sarcoma cells took up the stain and showed a strong diffuse staining with Desmin. On the right top area, you can see the adenocarcinoma cells, not staining for Desmin IHC. Now, we did also cytokeratin, and as you can see, it has an inverse profile, staining diffusely the adenocarcinoma component. As you can see, it's also quite interesting. If you look in the sarcoma component, some of the sarcoma cells actually demonstrated cytoplasmic staining with cytokeratin. Actually, around 30 to 50% of carcinosarcomas, their sarcoma component will actually demonstrate cytokeratin, variable intensity of cytokeratin staining. So it tells us that in terms of immunophenotyping, the sarcoma is really related to the epithelial element and supports the theory of conversion or metaplasia. This is just a picture showing adenocarcinoma nests or nest of tumor cells plugging the lymphatic channel. So this is compatible with lymphovascular space invasion. The tumor involved the perirectal soft tissue as well as some of the lymph nodes, the liver, the spleen, the omentum, and the final diagnosis in this case is carcinosarcoma with heterologous or rhabdomyosarcomatous differentiation. All of the submitted specimens, including the rectum, is involved by the neoplasm. There is lymphovascular space invasion, and all the surgical lines of resection are negative for the tumor. Now, just a quick discussion of carcinosarcoma. Carcinosarcoma, by definition, is a high-grade malignant biphasic tumor comprised by carcinoma and sarcoma components. As discussed previously, it could be either heterologous or homologous. Homologous meaning the sarcoma is comprised by leiomyosarc, endometrial stromal sarcoma, or fibrosarcoma. Heterologous if the sarcoma has differentiation towards skeletal muscle, rhabdomyosarcomatous, fat, liposarcomatous, bone, osteosarcomatous, and cartilage, chondrosarcomatous. It's a rare and aggressive neoplasm, usually seen in the post-menopausal women, and is usually found in the uterus. Because of the varying amounts of mesenchymal component in these tumors, they tend to have structural integrity and usually presents as a bulky polypoid mass that usually protrudes through the cervical os. For the histopathogenesis of our carcinosarcoma, we have 4 actually proposed theories, but 2 of them are the most widely accepted and popular. That's going to be the combination and the conversion theory. Among the 2, the conversion theory seems to be the most cited, and it tells us that the sarcomatous element is derived from the carcinomatous element. So what the theory is telling us is that the carcinoma, through tumor progression, eventually repossess the capability or some degree of pluripotency, and thus is able to change from an epithelial type of tissue into a mesenchymal type of tissue. So Dr. Atino actually discussed this very good, the epithelial mesenchymal transition, which occurs in normal tissues. Usually, it occurs in wound healing, in which the remaining viable epithelium will need to differentiate towards the fibroblastic and myofibroblastic differentiation to promote wound healing. It is also present in embryogenesis. So some of the authors is telling, they tell us that these carcinosarcomas, they repossess that capability of transforming from an epithelial into a mesenchymal differentiation. That's why one of the popular names for carcinosarcoma is metaplastic carcinoma. So because of that proposed theory that these tumors are really carcinomas, just having a sarcomatous differentiation, the behavior is therefore also compatible with that of a pure carcinoma. The pattern of spread is also similar to that of a carcinoma. And if you look at the metastatic deposits of this tumor, most of those deposits will harbor the carcinoma component. Rarely would they have a pure sarcomatous component? And even if you do immunohistochemistry study, you will see that the sarcoma component will produce or exhibit cytokeratin staining. So all of those features tell us that this tumor is really first and foremost a carcinoma, and that the carcinomatous component drives the prognosis and the aggressive behavior. Now, there are some similar case reports of pure endometrial carcinomas recurring as carcinosarcomas. In these articles, they encountered endometrioid type carcinoma, moderate to poorly differentiated, that was resected and later on recurred as carcinosarcomas. Important also is that they provided indirect evidence of tumor progression, meaning the original carcinoma component is of lower grade compared to the carcinosarcoma recurrence. They did that using immunohistochemistry study for P53, in which the original carcinoma component showed focal staining for P53, while the recurrence of carcinosarcoma showed diffuse and strong staining for P53, supporting the concept of tumor progression and metaplasia. The prognosis for carcinosarcoma is generally very poor. Poor prognosis could be brought upon by large size of more than 5 centimeters, myometrial invasion of more than 50%, LVSI, sarcoma predominance, serous histology, and heterologous rhabdomyoblastic differentiation. For us pathologists, the diagnosis of carcinosarcoma is frequently rendered in the surgical resection. Why? Because you need to identify the high-grade carcinoma as well as the sarcoma component. So we encounter challenges when we receive biopsies and curettage, because most of the time that's limited tissue sample will only harbor one of the two components. So in those instances, immunohistochemistry study will help. If you're going to encounter a poorly differentiated neoplasm that has sarcomatoid features in a postmenopausal patient, and mass is a polypoid mass, then you can actually do Desmin staining or some sort of mesenchymal IHCs to first prove that there is a mesenchymal component, and then you can do cytokeratin staining also. And if the cytokeratin stain is taken up by the sarcomatous component, then you can suggest that you are dealing with a carcinosarcoma. But you can only suggest, and it will never be definitive. In the end, you have to identify both the high-grade carcinoma and the sarcoma component, and you're going to do that most of the time in the surgical resection specimen. Some of the immunohistochemistry studies can also be helpful in separating carcinosarcoma from its histologic mimics. Some histologic mimics of carcinosarcoma includes adenosarcoma and endometrioid adenocarcinoma with spindle cell features. In those tumors, they do not express P53 and P16 in a very diffuse and strong pattern. In contrast to carcinosarcoma, which usually expresses these immunohistochemistry stains in a very diffuse and strong pattern. So that is my last slide. So thank you for listening to my presentation.
Thank you very much. We have another reactor in the person of Dr. Jean Antoral. She is Professor 2 of the Department of OB-GYN at the UPPGH College of Medicine. She completed her residency training in OB/GYN and subsequent fellowship training in gynecologic oncology, also at the University of the Philippines, Philippine General Hospital. She is a fellow of the POGS, of the Society of Gynecologic Oncologists of the Philippines, and the Philippine Society for Cervical Pathology and Colposcopy. She is a graduate of Masters in Science in Clinical Epidemiology at the University of the Philippines College of Medicine, and she is presently the treasurer of SGOP and president of the Asia Oceania Research Organization in Genital Infections and Neoplasia Philippines. Dr. Tural?
Good evening. It's already past 6. Good evening, everyone. Thank you very much, Joy, for the introduction. And congratulations, Lilia. I agree with the adjective of Joy. Interesting discussion. And thank you, Dr. Rivera, for the review of pathology as well as that of the pathogenesis of this disease. Your discussions make my job much easier. So let me just share my screen. Okay. So this is the clinician's reaction, no? So my disclosure in relation to this presentation, I am the attending physician of this case. No? So let me just show you on one slide what happened to this patient. So I got her after the endometrial curettage. So she was referred to me. So she was a stage 1A endometrioid adenocarcinoma, grade 2, and I didn't give her any additional treatment because she's a stage 1A, limited to the endometrium, and she had no evidence of disease for 1 year and 6 months. Then came the tumor recurrence. So chemotherapy for 3 cycles, then followed by MRI evaluation. So then afterwards, I decided to stop chemo because she wasn't responding. I needed to do surgery and had to do it with surgery. And then came the lockdown after she was operated February, and then came the lockdown. So she wasn't able to follow up with me, but I would see her through Viber calls until it was the end of the road for her after 3 months. At this time also, so the questions in my mind then was, why did she recur? No, she was an early stage disease. What did I miss, and why that pattern of recurrence? No, just all of a sudden so much tumor. I did not have the answers, so I treated her as a case of recurrent endometrial cancer, and it made me really wonder. Okay, so why the decision to reoperate? Because the patient was not responding to the systemic chemotherapy. These are the pictures, no? The abdominopelvic mass, the spleen, the omentum, the rectosigmoid. And what made me wonder again, the histopath turned out to be carcinosarcoma with heterologous elements. So my wonder doubled. And then while still managing this first case, another patient, I was also handling another patient. This is a 56-year-old G1P1 1001 who was operated abroad for a stage 2 endometrioid adenocarcinoma, grade 2. And she was given high-dose rate brachytherapy in that country also. She had no evidence of disease for 9 months, and she was regularly following up until she came back to me with a right pelvic mass, about 15 centimeters in greatest diameter. It was with limited mobility, so I decided to give, again, chemotherapy with taxane platinum, the same as the first patient. And here, the lockdown, we were caught in the lockdown in the GCQ, and instead of having surgery after the 3 courses, I extended it to 6 because we didn't have guidelines yet, or the guidelines were still changing with regard to there was surgeries were halted at the time of COVID. And when she finished the 6 courses, I was supposed to operate on her a month after the last chemotherapy. And then she turned out COVID positive. She was asymptomatic. So that gave another delay of another month. But we were able to do the tumor debulking surgery. And again, carcinosarcoma, ang histopath. So, and then I decided to give her additional 3 courses of chemotherapy. And it's been 2 months from her last chemotherapy, and she's still okay. So it's been 17 months total so far from the time she had her first surgery. So again, these were the pictures from that second case. And again, the histopath was carcinosarcoma, this time homologous elements. So again, wonder, why did I have such 2 cases coming almost one after the other? That's why when Dr. Ana Diecho asked me, Dr. Toral, if I have a interesting case I wanted to present, maybe I answered her a week after. So I go, let's see if we can present this one and if it would be interesting, because I don't really know what happened to these 2 cases, and it would be good to share it with everyone to see what really happened. And that was exactly what Lilia did. No, she looked into how this phenomenon could have happened, no, from endometrioid adenocarcinoma to carcinosarcoma, no. So what remained to be my questions about these two cases? No? Both had endometrioid grade 2 for first a cystopath, then recurrence came in a short time, less than 2 years. The recurrence turned out to be carcinoma, both involving the peritoneum. The index case also had spleen involvement. The questions were, am I dealing with the same disease process? So is it a recurrence of the same original tumor, or is the recurrence actually a new primary? So those were the questions in my mind. So what we learned from Dr. Tino's discussion, of course, the rarity of uterine carcinosarcoma itself. It's even rarer to have them in the extragenital sites. Then, of course, the origin of the tumor with a conversion theory now more favored over combination. When I was a fellow, it was more of combination theory. And of course, the three possibilities for extragenital sites were discussed: endometriosis, splenogonadal fusion, secondary Mullerian system, or the involvement of the peritoneum. So I'll just go fast through this. No, evidences for a new primary in extragenital sites, no, in the literature. Let me go first with splenogonadal fusion. So this is a primary carcinosarcoma of the spleen in a male patient, no, 61-year-old. So they were thinking it's possibly splenogonadal. Then there's this one, a newer one in 2018 from Australia, primary extragenital mixed malignant Mullerian tumor, presenting as a painful splenic mass. Then what about primary peritoneal carcinosarcoma? I was thinking when I was going through this literature, my case could probably be that, no? But the difference is in this case series, they showed 30 cases already, and none of them had tumor in the uterus previously, no? So lahat sila talaga primary peritoneal. Adding to that, this series is from Taiwan, no? And then this journal is also again from Taiwan. Here, that was in 2004. This one is in 2018. So 2019, sorry. So that was 15 years difference. So parang they said they have already seen 40 cases reported in the literature of primary peritoneal carcinosarcoma, but none of them had previous lesions in the uterus. So this one is another one from Japan. What about endometriosis? I found this one, a June 2004 journal of retroperitoneal Mullerian carcinosarcoma associated with endometriosis. But and this one is a slide I borrowed from a previous lecture of mine with regard to endometriosis associated ovarian cancer. And you would see these mutations, no? So these are familiar: KRAS, phosphatidylinositol kinase, P10, ARID1A. So remember this, no? But although this is Dr. Manalo's favorite theory, endometriosis leading to malignancy, no? But to me, this is probably not the theory for this case, no? Both my cases did not present with ovarian lesions. Both are also postmenopausal. Most likely, it's possible that we can implicate the secondary Mullerian system concept if we want to believe that the disease process is from endometriosis to explain the peritoneal recurrence, no? But then again, because there were no previous ovarian lesions, most of the association of endometriosis becoming carcinoma usually is in the endometriomas, no, of the ovary. But in this case, there are no evidences for that. So, what are the patient events? So, I'm not leaning towards it coming from endometriosis, nor but there is still that possibility that this is primary peritoneal carcinosarcoma. But what are the patient? But the other thing is, it might be just one disease process after all. And what are the molecular evidences for this? Okay, so of course, both Drs. Tino and Rivera discussed these theories on the origin of carcinosarcoma excellently, and we're believing that it's the conversion theory now, so a single epithelial component hypothesized to undergo metaplastic differentiation to the mesenchymal component. So you have the two components of the carcinosarcoma. So I'll show you the three most favorite slides I have from Dr. Lilia's presentation. No? So this one, did you show this, Lilia? No? So because when I asked her to send me her report, I got these three slides. No? So this just shows you that the primary tumor, both the carcinoma and sarcoma component, including those of peritoneal metastasis, had the same molecular profiles. The mutations were the same. Phosphatidylinositol kinase, then P10, PP2R1A. So lahat sila the same for all, no? So carcinoma, sarcoma, and peritoneal metastasis. And this is the other favorite, epithelial to mesenchymal. And Dr. Lilia excellently explained this. And this is actually supportive of the conversion theory that from the epithelial, the carcinoma component giving rise to the malignant mesenchymal component through a transition process or dedifferentiation or metaplasia, as Dr. Rivera said. Okay, but this is my most favorite. No, so you have here this because this slide can probably explain what happened to my patients. No, so you have here the two genotypes of endometrial cancer, the endometrioid-like. So you have here the type 1 and you have the serous type genotype, the type 2. So yun yung mga serous. So let's forget about this. Let's focus here. No, and it said here, this is a study based on molecular profiling. So the mutations found in these tumors were seen. So for type 1, you have P10 mutations. It's the most common mutation seen in the grade 1 endometrioid tumors of the endometrium. But here, you look here, so P10, but you have here additions. Phosphatidylinositol kinase, ARID1A, CTNNB1, KRAS, and microsatellite instability. But there is an addition here, no, of, so you have that, and then you have this. So what happened to my patient? She actually was a case of low-grade endometrial cancer at the start, but became carcinosarcoma later on. So here you have the poorly differentiated type, the endometrioid grade 3, including carcinosarcoma. So what could have possibly happened to these patients? No? My question is, did the P53 mutation come later in the disease process that we only saw low-grade endometrioid adenocarcinoma at the onset, no, in the uterine specimen? But when they already mutated or when they recurred or progressed, it was the P53 pathway which was already driving this process. So that's why I like this slide very much because, well, this is what I thought probably is the reason why my patient became like that, no, from an endometrioid grade 2 to carcinosarcoma when it recurred. Okay, so this is another slide I use siguro mga 3 times na in my lectures, no, just to show you the difference between overactivity and underactivity. And remember this, again, these mutations found in the carcinosarcoma. So when you say overactivity mutation or a gain of function, you need only one hit and you will have the expression of the mutation. Both of these, overactivity and underactivity, will result in cell proliferation leading to cancer. But if it's a gain of function, you need only one hit. So it's the same. That's the method for phosphatidylinositol 3 kinase, CTNNBS, and KRAS mutations. While loss of function is, the examples are P10, P53, ARID1A, microsatellite instability. Here, what happens is you need 2 hits because one hit in a normal cell will not manifest the cancer. But you need 2 hits to, let's say, P53, the tumor suppressor gene, to be able for cancer, the mutation to happen for cancer to occur. And we know the reason why I highlighted P53 is because P53 is the probably most frequently mutated gene in the human body, and it can really wreak havoc across our epigenome, microRNA structures, etc. And there are so many cancers really associated with p53. The reason why I highlighted phosphatidylinositol-3 kinase is because this is one pathway wherein if you it's associated with the mammalian target of rapamycin or mTOR. And if you are able to see this mutation in your tumor, it's possible that you can give mTOR inhibitor. So it's an actionable mutation. So there are mTOR inhibitors like your everolimus, sirolimus, which could probably work for cases with this mutation. Okay? So, as again, P53, this is again a slide I always use, no? P53 is there probably the reason why the endometrioid cancer became carcinosarcoma. And we have to learn from the elephants, no? Kasi elephants, though they're big, statistically, they should develop more mutations. But very less than 5% of elephants died of cancers, but in humans, up to 25% will die because of cancer. And this is because humans have just one pair of p53 genes, so it just needs two hits and you can manifest the cancer. While elephants have 20 pairs, so you need 40 hits before an elephant can have cancer. So they probably will die of poaching, no, because of their ivory tusk, but they will not die because of cancer. Okay? So yan, so this is the 20 pairs in the elephants compared to just one in humans. Okay. So again, so this is my most favorite slide, which probably is I want to explain what happened to my patients this way. And yeah, this is my last slide, I think. What do I think happened to these two patients? So this is my theory. You can always argue. You can still say it could still be primary peritoneal, but we welcome a healthy discussion. I think this is a transition from epithelial to mesenchymal, favoring the conversion theory. And the p53 mutation came later in the disease spectrum and involved the other sites, primarily those of the secondary Mullerian system. Primarily the peritoneum, diba, the disease was in the peritoneum after the uterine surgery. But this can only be verified if we do molecular profiling of the original endometrial tumor and the peritoneal disease to see the mutations involved. For all we know, I may be wrong. It's probably pala primary extragenital, primary peritoneal carcinosarcoma. And you might ask, what for? No, the patient is already dead. The first patient is already dead. But I still have the second patient. And you might also get a similar patient. And doing molecular profiling can probably help and see if there are mutations that can be actionable and be given other medications. So let me end by sharing with you this quote from the great Greek philosopher Socrates. No? Wisdom begins in wonder. And let us all be wanderers. So let us thank the patients that come our way to make us wonder. Thank you very much.
Thank you very much, Dr. Toral, for that discussion. So I think it's scary to think, no, that we are seeing more and more early stage endometrial cancer recurring, and in the case of Mom Jean's patients, recurring not just as endometrioid type but as carcinosarcoma. So I think we have a couple of questions in the Q&A box. I would like to call on our three speakers. So we have a question for Dr. Toral. Ma'am Jean, what could be the risk factor for recurrence? I think Ma'am Jean already dwelled on this a bit.
Probably it's the mutation, no? Thinking it could, siguro mutation siya kasi they are both early stage, no?
Yes, and um, in practice, we don't usually recommend adjuvant treatment for early stage low risk endometrial cancer, and yet these patients had recurrence and carcinosarcoma at that. Okay, so can we have the next question, please? So the next question goes to Dr. Rivera. What is the incidence of endometrioid carcinoma progressing or becoming carcinosarcoma in your experience in the Department of Pathology?
If you're asking me for a figure, ma'am, I can't actually give you on the top of my head. But it's not that common. As you can see, if you search literature, you're going to just encounter a few cases of pure endometrial carcinomas that actually progress to carcinosar. More so in this case, you're dealing with a pure endometrial carcinoma. Most of the reported cases of pure carcinomas becoming carcinosarcomas are actually from the ovary. And the explanation is more easily acceptable because the primary carcinoma is already high grade. It's usually a serous that eventually, when it recurs, it's a carcinosarcoma. So I can't actually give you a number, but it's going to be rare.
Right.
Also, there is a question with regards to endometriosis becoming a carcinosarcoma. I can also give you a number, but that's even rare. Endometriosis becoming a carcinosarcoma. But is it possible? Yes, is it possible? But if you encounter this type of situation in which you have first a pure endometrial carcinoma and then later on you encountered a carcinosarcoma, the paradigm there is that the carcinosarcoma most probably is just a recurrence of the endometrial carcinoma that undergone tumor progression. But things will change. I think as we accumulate more evidence, we have more of these cases, we are able to do gene profiling or molecular testing. Things could change. The way we see things could change.
Right. So now that you mentioned about tumor profiling, Dr. Tural, do you think performing tumor profiling on your patient could have helped? Although parang short na yung time, no?
Mm-mm. Yeah, short time, and I didn't know of this the presentation made by Lilia regarding the possible theory. No, I didn't know about this. So yun na nga, when it turned out to be carcinosarcoma, I followed what is in our treatment protocol to give taxanes and carboplatin. But maybe if my second patient who's still well recurs again, then that would be a good time to do molecular profiling and see if, let's say, she can have some actionable mutations. Meron ng therapeutic targets for those.
Okay. Thank you, ma'am. So can we have our next question? So there's a question on the Q&A box. Is there a possibility that carcinosarcoma in the first specimen in the uterus when extrafascial hysterectomy was initially done, is there a possibility that carcinosarcoma was already present? No? And is there a need to do a slide review?
Do I answer that?
Like Nanjing. Yes.
Ano, that was my first question. Was there carcinosarcoma? But Jonathan reviewed it, right? And there was none. There was none. So that makes this case different with the primary peritoneal carcinomas, carcinosarcomas presented kasi nga walang uterine tumor yung iba. And then it was really an endometrioid adenocarcinoma, I think. Not, you agree, Jonathan, di ba?
Actually, yes, ma'am. Actually, when for example, this case, the first question would always be that: is there a possibility that from the onset it's a carcinosarcoma, it's not an endometrioid? And most of the time, it could be. No, that's why you have to have the slides reviewed. And actually, as my advice to gyne oncologist, you also ask how many sections were taken. That's actually also an issue. For this case, I believe adequate sections were taken because there's always a possibility that a small focus of sarcoma is present in the original specimen that was not represented when sections were taken. But as long as you just have to confirm whether the sections are also adequate. So it's a possibility. Most of the time, actually, it could be that there is already a brewing sarcoma in there. For this case, we don't have evidence for that.
That's why for us oncologists or pathologists are really our best friends. You have to be on our quick call list, no? Because well, I think Jonathan mentioned that there are cases where when we do endometrial biopsy, the initial result would be an endometrioid type, but in the final specimen, we see eventually that it is really indeed carcinosarcoma. But in this case, as yes, a slide review was done, and endometrioid carcinoma without the presence of a sarcomatous component was confirmed in the initial biopsy. But all the specimens that were removed in the second surgery already showed sarcomatous component, carcinosarcoma result. Okay, so I think we have a few more questions. We have a question from Dr. Buizon. Sir Dan asked, what could have caused the P53 mutation in the index case who did not undergo radiation? Uh, Ma'am Jean, would you like to answer the question?
Ah, what could have I don't know really. 'Yun, hindi ko alam ang sagot. Ah, kasi it's something what could be the factors that cause the heat, 'di ba? Parang gano'n yung gustong sagot it was asked by Dr. Buison. What could have it be, no? I don't know. Environment, it could be maraming factors, but I don't really know one specific factor. For carcinosarcoma, it said here, tama, radiation is one, yung previously irradiated pelvis, tapos nagkakaroon ng carcinosarcoma of the uterus, but I cannot think at offhand na kung ano specific to cause the heat.
Yes, and it's very perplexing on the part of the clinician, no, that you see a patient.
Enigmatic yung P53.
Yes.
Difficult to understand.
So
Maybe
yes, but
can I, from the top of my head, if I'm going to make an answer, ma'am, maybe the P53, as Dr. Torral said, we don't have an exact mechanism or causative agent for P53. But if you recall basic, let's say, pathogenesis of tumors, mutations usually stem from either activation or inactivation of proto-oncogenes and tumor suppressor genes. And if you look at the proteins that those genes produce, they actually are related with cell repair, ability to repair themselves. So they're actually more prone to mutations. So over time, if you let these tumors grow on the patient, it's not going to be surprising for them to progress eventually. So I cannot answer the P53 exactly, the exact causative factor, but it's not going to be surprising P53 mutation. And if you look at high-grade tumors, those that have progressed from lower-grade neoplasms, they tend to have P53. It's like the signature of being high-grade. So that is my answer.
That's true.
thank you. So okay, so there's another question. Is it possible that carcinosarcoma was independent of the endometrial cancer, and is there a way to check if the malignancies are related? Maybe Jonathan can answer.
Profiling.
I'll try to answer. Maybe they are related. That's a possibility. First, the possibility is they are recurrence of the primary endometrial cancer. The next is you cannot completely or absolutely discount the possibility of what of the other mechanisms, the endometriosis or the extragenital rest, Mullerian rest in the retroperitoneum and in the pelvis. But you have to provide evidence. In this case, we don't have evidence for endometriosis. At the same time, you have a previous history of an endometrial cancer. The only way to maybe have an answer is to do molecular testing. If the recurrence or the carcinosarcoma shares the same driver mutation with the primary endometrial carcinoma, then you will be confident that both are related. If they are completely distinct, the driver mutation, whether it's P10, P53, or the microsatellite instability abnormalities, then you can propose that those two are separate and malignancies occurring metachronously.
Thank you. Okay, so there's a question regarding the prognosis of carcinosarcoma. Is there a difference if it arises from a primary endometrial adenocarcinoma, and if there is a difference in terms of management? Maybe Ma'am Lilia? Ma'am, I think your mic is turned off.
Sorry, there. Yeah. Okay, so I think, sorry, the question, I got lost.
The question
The
was about the
difference
prognosis. Yes, if there's
in
a
terms of
difference in
prognosis, I think there's none. Uh, I'm not so sure, but I think there's no difference because it's you take it as a carcinoma, whether it came from a primary adenocarcinoma or a primary carcinoma to start with. I think there's no difference in the prognosis. And the second question is
I think it. Yeah, I think that if there's a difference
in
in
terms
terms
of
of
in terms of
management.
management. No, you treat it as a carcinosarcoma case.
So I think it was mentioned a few times during the discussions, no, that it will follow the carcinoma. Am I right? The
Component.
carcinoma component. Yes.
Yes.
And there is a question, I think, related to this previous question. If there is a is it possible to have a pure sarcoma of the uterus? No? And um, maybe Dr. Lilia, yes, it is possible.
Yes.
You can have a pure
It's,
sarcoma, no,
yes,
but
sir. It's a different category. Carcinosarcoma used to be a sarcoma of the uterus, but now it's as I explained, it's now part of the endometrial carcinoma, the epithelial kind, because it behaves more, and because of the different studies, it's more proper to categorize it with the endometrial carcinoma rather
yes,
than a sarcoma. Sarcoma, sir, we have the different kinds: the leiomyosarcoma, endometrial stromal sarcoma, or adenosarcoma, and the undifferentiated high-grade sarcoma.
yes, and their behavior and the treatment differs.
Right.
While carcinosarcoma behaves similar to an epithelial type, that's why we manage them similarly as we manage the pure endometrioid type. So I think we have a few more questions. I think this goes to our pathologist. What is the sensitivity of frozen section in the diagnosis of carcinosarcoma?
To be honest, I don't know, man. But will it be helpful? In certain cases, it could. However, the limitations of frozen section stems from the number of some sections that you're going to take. Again, if you're going to have a carcinosarcoma with an epithelial predominant pattern, you're not going to simply get it in frozen section. You have to extensively section the malignancy. So maybe in a subset of cases, it's going to be helpful, but it's not routine. I believe it's not a routine practice to diagnose carcinosarcoma.
So I guess it will be the same as with any tumor of the uterus, no, that we send for frozen section. You will be limited by the number of
Yeah.
samples that we can run. We have time for just a few more questions. There's a question, or two questions rather, from Dr. Grace Sabado. And I think this goes to Dr. Toral. What chemo regimen was used in the second patient? And, okay, ma'am, go ahead.
It was paclitaxel carboplatin. And she had good response. Now we were able to debulk the tumor completely.
So, and then a follow-up question is, with case reports like this, would it eventually influence the way we monitor or follow up our endometrial cancer patients? No, because we used to think that endometrial cancer, especially early stage, is a relatively good tumor, as we used to say it. But now we're seeing more recurrence, no, in even in early stage low risk patients. So maybe yes, Ma'am Grace, there will be some change in the way we monitor our patients.
We will still
So
monitor them closely.
yes.
These two patients are very religious followers, no? I mean, they would come on the day that they were really scheduled, no? Kaya it really made me wonder what yung recurrence nila. Parang ang laki kagad ng mga tumors. And maybe because P53 driven pathways talaga. But we don't have the profiling for both cases. The molecular profiling.
So there's another question in the Q&A box asking about endometrioid cancer in a patient who took HRT. So there's no particular mention of which HRT, but who would like to answer the question? The
One of the
question
yes, exogenous use of estrogen can predispose a patient to develop endometrial cancer.
so it is a risk factor actually. Okay, and then maybe one
Especially,
last question about the possibility of first degree family members getting the same type of aggressive cancer from Dr. Laban. So probably the question is about if there's a familial tendency for these types of cancers.
For endometrial cancer, the only one established to have hereditary predisposition is the Lynch syndrome, hereditary non-polyposis colonic cancer syndrome. But all the mutations I was mentioning earlier are somatic mutations. No? So except for yun na nga, HNPCC, which is associated with microsatellite instability, MSI.
So we thank you for all of your questions. I was quite overwhelmed by the sudden barrage of questions. Very interesting topic indeed. Thank you very much to Dr. Lilia Tino, our pathologist, Dr. Rivera, and Dr. Jean Toral for sharing your cases with us. So we would like to remind everyone to answer the evaluation form with the link for which you can find in the chat box. Please don't forget to answer in order to get the full count of attendance. Okay, so to wrap up this tonight's conference, I would like to call on the Vice President of SGOP for 2020, Dr. Filomena San Juan, to give the closing remarks.
Thank you. Thank you, Joy. Today, we honored and remembered our esteemed and highly admired Professor Dr. Augusto E. Manalo, who was like a father to most of us gynecologic oncologists. Dr. Manalo is one of the most respected and beloved professor in gyne-oncology in the Philippines. The topic endometrial cancer is close to his heart and his favorite topic, as well as the carcinosarcoma, ably presented by one of his mentee, Dr. Maria Lilia Bernadette V. Tinio. Congratulations, Dr. Tinio, for the excellent discussion of this tumor with several theories. Our gratitude to our brilliant pathologist, Dr. Jonathan P. Rivera, for the detailed description of the histology, which made us appreciate pathology because of the clear photos of the histology and immunohistochemical staining. Dr. Jean Ann Toral gave her in-depth discussion on the management and presented the different theories that result to carcinosarcoma. Her discussion make us wonder, is this a recurrence or another primary? Her search of literature showed several cases without a uterine primary, which could be so that this case could also be a second primary peritoneal tumor. She favored the conversion theory as a possible explanation to the occurrence of carcinosarcoma. We thank Dr. Rose Joy Vallega, our moderator, for providing a smooth flow of the program and ably handling the question and answer portion. Most of all, I'd like to thank the organizing team, the Tumor Conference team, who organized, facilitated, and announced this conference through the leadership of Dr. Ana Diecho. We thank Dr. Mark Antonio and his team for the technical expertise, giving us clear audio and video in this afternoon's conference. This conference would not have been possible without the kind sponsorship of AstraZeneca. Thank you for your support, AstraZeneca. In behalf of the Board of Trustees of the Society of Gynecologic Oncologists of the Philippines, through the leadership of our President, Dr. Maria Lilibeth Shiasu, we would like to thank all those who participated and listened to this afternoon's conference. We hope that we learned more from this tumor conference, and we hope to see you more again in our future tumor conferences. We would like to thank all of you and all the participants, and keep safe and be happy. Back to you, Dr. Joy.
Thank you, Dr. San Juan. Once again, we would like to remind everyone not to forget to fill up the Google form, the evaluation form, which can be found in the chat box. You will need to complete this in order to get your certificate of attendance. So this wraps up a very productive evening. Thank you to our sponsor, AstraZeneca. Thank you everyone for attending the SGOP Augusto M. Manalo Tumor Conference, the third in a series of 3 for this year. We hope you have endometrial carcinoma in its varied forms. We hope you could join us again in future tumor conferences. Good evening and God bless. Stay safe, everyone.
Thank you, everybody. Good night.
Congratulations po.
Thank you po.
Congratulations,
Picture
galing.
tayo.
Very
Thank you po.
interesting.
Pwede na isulat, ma'am.
Oh, ma'am, interesting
Sulat
things
po.
pwede
Actually,
i-publish.
maraming kaso tayo ngayon na na early recurrences.
Sana
Konti lang kasi
ma-molecular profiling para maganda.
dapat lahat ng patients natin in first surgery may molecular profiling na para sila ay pwede nang hindi na nag-aantay ng recurrences gene.
Oo nga, ma'am eh. Kaya lang, syempre, ang mahal eh, di ba? Oo.
Yeah, but that's a life save.
Oy,
for
pero
so
totoo,
much.
ma'am.
Yeah,
Correct.
there's some patients who spend so much for the chemotherapy, radiotherapy, and
Hindi
hindi
naman
naman pala
nag-work.
kailangan.
Oo.
Oo, iba pala ang kailangan nila. So,
Correct.
we should push for that, you know.
Ma'am, wala na magpapakingit mo.
Alam mo?
Sa profiling pa lang, ma'am, baka maubos.
Kaya lang, yun kasi yung para ma-direct yung treatment.
Oo,
Diba?
kasi
Para
sayang
ma-direct.
ang gastos din ng chemotherapy for 6
Oo nga.
courses cost mga 100,000, another
Tap.
100,000 for RT. Tapos kung hindi naman pala
Mali
kailangan
naman
yun.
pala.
Oo,
Mali
hindi naman
pala.
pala siya ang kailangan.
Oo nga, ma'am. Totoo yan.
And then once you find out, it's already too late. There's already recurrence. Diba?
Mark, picture tayo.
Ma'am,
Okay lang. Ma'am, 1 minute, ma'am. Magbibihis lang ako. Nakapambahay.
Nakakatawa
Okay lang
naman
daw.
po si
Okay
Mark.
lang daw. Na wala. Topless.
Ang nakikita ko lang sa sarili ko. Meron pa kasing siya. Ba't hindi ko kayo nakikita?
Hindi ko nga nakikita
Oo nga,
kayo.
hindi ko kayo
ma'am.
nakikita.
Nakikita ko lang yung slam.
Naririnig ko lang kayo. Naririnig
Kasi
ko lang kayo.
hindi tayo ginawang video on lahat.
Hindi ma'am, pero pag sinara mo siguro tong SGOP Tumor Conference, hindi ba tayo lalabas lahat?
Lalabas, ma'am. Sorry po. Wait lang.
Ayun!
Ayan.
Nagsuot na kasi ng damit ni Mark.
Ay, Mark, labas
Profile
yung sarili mo. Yan. Sino yung isa pa?
Sabi na
Sino, ma'am
nagsuot na
Cheska, ma'am? Si ma'am Cheska.
Ma'am Cheska, one picture lang. Game? Ay, Ma'am Cheska, wala ka. Ayan.
Bakit ba ganito? Hindi pantay.
1, 2, 3. Thank you. Thank you
Thank you,
very much.
ma'am.
Thank you. Congratulations again.
Ana,
Congratulations sa inyo lahat.
Thank
Ma'am,
you.
ma'am, tapos di biglang nawala nung magsasalita na. Nagpanik
Oo,
ako.
ma'am, hindi ko nag-camera on.
sino?
Doktora San Juan.
Hindi naman. Wala kayong video nung nagsasalita kayo.
Wala ako?
Wala
Hindi
na
ko
yung video.
on.
Naka-off ka, ma'am.
Nakalimutan
Wala,
mag-unmute.
nilagay mo yung picture ko.
Ay, yes, ma'am.
Yes, ma'am.
Okay lang yun.
Thank you, Jonathan.
Jonathan, thank you.
Bye. Congrats,
Thank you,
everybody.
Jonathan.
Very good discussion, Dr. Jonathan. Thank you.
Ang galing ni Ma'am Jane, sobrang expert na siya sa mga mTOR.
Hindi nga.
Oo nga, gulo utak namin. Din.
Ano ma'am? Sorry.
Gulong-gulo utak namin sa dami. Dami ng theories.
Nakalimutan. Nagbasa na ako sa
Hi,
inyo.
Jonathan. Hindi ba yan pwedeng maging available sa ating laboratory? Yung
Ala.
molecular
Meron na
profiling.
tayong PDL1. Di ba? May
Oo.
Ma'am,
PDL1
ma'am, dito nga sa Pampanga, ma'am, ang immunohistochemistry lang na available sa amin ay ERPR tsaka HER2 nyo lang.
Kasi sa breast yan, mas maraming breast kasi.
Malayo pa tayo.
Sobrang hirap, ma'am.
Pero ang
Sobrang
dami
hirap.
kasi natin kailangan for gynecologic cancers.
Ma'am, yung nag-lecture tayong Astra, di ba? Nung Sabado ba yun? Yung Pacific, yun yung mention ko dun sa lecture ko, yun yung company na yun. Di ba dalawa yung Actigenomics sa Pacific? Sila yun.
Oo.
Korean ba siya? Ay, basta Asian.
Kasi kung maraming cases,
In the future,
bababa yung costing na yan eh.
yung cost.
Oo.
Yes.
Wala ba kayong
Pagmura
Ma'am,
din
because of COVID.
frozen? Wala bang frozen ano kayo? Itatago lang yung mga yung mga tissue kasi hindi na mabalik
Tayo,
yun.
tayo yan.
Meron tayo.
Tayo, ma'am.
Ha?
Pero yung ma'am, tinatago, ma'am. Tinatago po yun.
Kaya.
Pero tinatapon
Kaya.
after 10 years ata, ma'am. After 10 years.
Ay, siguro in 3 to 5 years meron ng pondo para diyan. Di itago natin yung sa
Wala
mga
nga pondo para sa hazard pay ng mga nurses natin.
added trabaho. Hindi natin bibigay sa kanila, siguro mabubulok yun. Kailangan ng mag-hatid frozen section dun sa pathology, yung ating fellow or resident. Para hindi masira.
Siguro, Jean, kailangan sumulat ang ating section to request for
Actually, ma'am, pati yung ibang tumors, kunyari si Dr. Wang, di ba, sarcoma siya, nag-ano siya di ba, Jonathan, yung mga sarcoma,
Yes, ma'am.
collect niya.
Kinukulit na tayo.
Variant nga lang eh.
Sige lang tayo collect, patay na yung pasyente natin. Dapat ginagawa natin for patients. Huwag na naman natin antayin mamatay na yung mga patients.
At least in the future, may result na tayo agad.
Yeah.
Hindi tayo mag-aantay ng pasyenteng darating.
In soft tissue, ma'am, meron na pong molecular. Nagsistart na yung soft tissue. Sa gynae, wala pa po eh. Pero yung mga ortho kasi very strong sila. Even neurosurgery, very pinupush na kami talaga na mag-molecular. And because of COVID, nagkaroon kami ng molecular. Ngayon may fish na po kami.
Oo nga.
May fish
Alam
na kami.
ko na, Jonathan, may 6.5 billion for next year. Dapat sinama mo yan sa wish list.
Sinama mo yan sa ano mo.
Next year.
Nang walang hazard pay yung mga nurses.
Sinehead
Hindi
ng
kasama sa
molecular
wish
nyo.
list ang hazard pay. Maraming ang renovation ginagawa dyan sa garden, yung nasa harap. Sabi ko, ay, ba't ang daming ginagawa na naman dito tapos walang pambayad sa hazard pay. Pero that's beside the point.
Malay mo, Jean, itong COVID, isa to sa mga kaya nag-mutate yung mga tumors na yan. Nagiging aggressive.
Deputy Director na si Dr. Shasu.
Malapit na ako mag-retire, Mark.
Abangan natin.
We'll enjoy retirement. Yes, Jonathan, you push for that. Truly, it can help our patients. And then the government will spend less for the chemotherapy, radiotherapy, yung binibigay nila for patients in PhilHealth and everything else. Matatanggal yun. Mas malaking fraction yun.
Maraming problema.
Na-stress si Jonathan.
Yun lang, gamot ba tayo? Jean, wala yata yung mga gamot sa Pilipinas.
Ma'am, yung mga Everor meron, yung mga Everolimus, Sirolimus meron dito nun. Ang wala, siyempre, yung wala pa. Yung mga ganun. Oo.
Congrats, Lilia, ha? Cool na cool ka, ha? Mahirap yung case. Pero you were able
Panik kami, Lilia. Wala
Kasi wala siyang magsalita.
Wala po, boss. Sorry, ma'am, nakalimutan ko po mag-unmute.
Ang dami nang nagre-reklamo sa chat box. No,
Baka nakalayo na ako.
Hindi na pwede mag-unmute, Mark. Hindi
Matawag na eh. Hindi ko pinapansin.
Pag nag-self-mute kayo, ma'am, hindi namin kayo ma-unmute. Parang
okay.
din, ma'am. Pag nag-self-mute ka, hindi ka namin ma-unmute.
Okay. Okay, dapat pala in-unmute ko na from the start. Sorry
Yes,
naman.
Sorry.
Yep.
maganda. Very interesting.
Yeah. Galing si Joy, ha? Hindi nagpanic sa questions and answers, ha? May comments pa.
Oo, very cool. Very cool.
Okay, thank you.
Good night. See you tomorrow.
Bago na naman ito, Mark, ha? No? Bago na naman ito. Platform ito. Bago na naman. Kala ko, hindi ako StreamYard. Ito, StreamYard.
Ma'am, nag-StreamYard na tayo dati, ma'am.
Ganun ba?
Hindi na maalala ni ma'am. siguro.
Ano lang yun, yung sa dry run yun, Mark, nag-StreamYard
Hindi ako
tayo.
nakasama sa dry run yun noon, siguro.
Yung kay Dr.
May first time ko ito magamit.
Nag-senior tayo
Espanyol.
kay Dr. Minig at saka
Minig.
Yun ba yun?
yung pre-congress, ma'am. StreamYard tayo nun.
Okay. Kasi kinlik ko lang yung ano mo eh. Sanay ako sa Zoom. Click ko yung direct mo, kiniklik ko lang yun. StreamYard na pala yun.
Parang yun din ngayon. Click lang, tapos enter,
Oo.
no? Enter the box, whatever.
Yes, ma'am. Mas
Yes, ma'am.
mabilis.
Oo.
Oo. Okay.
Thank you
Sa
po.
susunod,
Good night.
Ana, thank you.
Thank you,
Ako
ma'am.
pa ang meeting ni Jean.
Bye, ma'am.
Ay, may energy pa tayo bukas.
Ay, oo nga.
Tapos
Kayo,
may
Tapos SGOP sa gabi.
OP.
Gabi
Sa
tayo, gabi. 6 o'clock.
Gabi.
Sige,
Okay.
ma'am. See you. Bye-bye. Thank you.
Bye-bye. Thank you.
Bye.
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 Bye po.
Bye-bye.
Balik tayo sa
Mag-leave
Greece,
ito.
niya. Sa Greece. Mag-dinner ulit tayo dun sa top of the hotel. Mag-dinner
Yes,
kami.
ma'am. Punta tayo.
Back.
Opo.
Okay.
Okay, ma'am. Take care.
Bye. Ano ba ito i-off? Yan.